Okay, we're covering the urinary system, and I'm going to go through the lab to cover and review what we're going to be, or what you're going to be required to be able to identify and describe a function. So we have our gross anatomy, which are the kidneys, the ureters, urinary bladder, urethra, renal artery, renal vein, inferior vena cava, abdominal aorta. We have, when we're looking at the kidney itself, we have regions of the cortex and the medulla. We have a renal capsule. And then we have our renal calyces, a minor and a major, and a renal pelvis. Then we're going to look at the microanatomy of nephron structures. We have what's called the renal corpuscle, which is composed of two structures technically, a glomerular capsule or Bowman's capsule. I still refer to it as a Bowman's capsule, and the glomerular capillaries contained inside. So as a unit, it's called the renal corpuscle. And this is where filtration occurs. We have then the collecting ducts, the distal convoluted tubules, proximal convoluted tubules, ascending and descending loops of Henle. Not necessarily in that order, that filtrate flows through, but that's the anatomy that you have to know. I also want you to be aware of and identify the juxtaglomerular apparatus, the afferent arteriole that contains the juxtaglomerular cells, and the distal convoluted tubule that contain the medulla densa cells. So together, the juxtaglomerular apparatus is where the afferent arteriole and the distal convoluted tubule touch on each other, and where we're monitoring glomerular filtration rate. So glomerular filtration rate is the amount of filtrate formed in both kidneys per minute, should stay at a constant, constant to maintain homeostasis at about, 125 milliliters per minute. So your question is, well, what hormone is secreted by the JGA? That's renin. This is where the renin comes from the renin-angiotensin system. And which cells secrete it? The juxtaglomerular cells. Remember, if it's a hormone, it goes into blood. So the cells that are within the afferent arteriole would be the ones, the JG cells, that produce the renin. Right, then we're going to trace blood flow through the nephron, right, putting them in order. We'll look at a couple different models, and the PowerPoint notes I have up there are excellent for giving you a not only more detailed background, in text of what we're referring to here as structures and functions of these things, the different macroanatomy and microanatomy, but also lots of images of models in addition to what's kind of listed here under the lab images, for each lab. There are other models that are used. And for those of you who are, are somewhat on campus, this will be very helpful. Okay, so we're going to put these structures in order. The renal arteries branch off into various smaller arteries until finally you enter into the renal corpuscle. So the vessel transporting blood into the renal corpuscle would be an afferent arteriole. And let's not forget, arterioles are capable of vasoconstriction and dilation, and thus are under the control of the autonomic nervous system, as well as we'll find as the endocrine system. Okay, so we have the afferent arteriole. Then that branches off into the glomerular capillaries. Then we leave that renal corpuscle as the efferent arteriole, and it will branch off and give off a capillary bed that will surround structures in the cortex called the peritubular capillaries. Also in the cortex will be not only renal corpuscles, but proximal and distal convoluted tubules, some small portions of collecting ducts. And it gives off another branch called the vasorecta that transports blood and supplies structures in the medullary area of a renal pyramid. And those would be the loops of Henle and collecting ducts. and they gas exchange at those capillary beds, and then they reform to form small veins to larger veins to even larger veins still, until finally we have our renal veins. Okay, so we're going to identify those on the models. Then we're also going to look at histology. I generally use just the kidney or the ureters and the ureters. And for some reason, there isn't a picture of a ureter on the course page. We're going to look quickly at the notes that I provided also. And we're going to kind of flip through those because I don't want to take a lot of your time for that. You can read that on your own. Okay, so back to the histology. You should be able to identify the regions of the cortex and the medulla by looking at the histology. And you do that by identifying renal corpuscles, because where you see renal corpuscles, you know you're in the cortex. Also found in that region would be proximal and distal convoluted tubules. And I'll give you examples of what questions might be like when we get there. Right, and then in the medulla is composed of pyramids, and they contain the ascending and descending loops of Henle and collecting ducts. So there'll be, you can really distinguish between the two, especially when we look at some of the pictures I have in the PowerPoint notes. The ureters, if we have a picture and if there is one that I, can help you identify within the notes, it's so easy to identify a ureter, much easier than looking at the layers of the urinary bladder, because the urinary bladder is so big. And generally, when you have a slide of the ureter, you have the whole thing on end, and it looks like a sand dollar kind of. And you can very easily see your mucosa, your muscularis layers, and the outer connective tissue layer, either adventitia or serosa. I don't distinguish between the two. And then, because remember, it's just a difference in terminology that you use between adventitia and serosa. It's a connective tissue. Yes, one is more fibrous connective tissue, the other is more areolar connective tissue, and that depends on where the structure is located. Is it within the peritoneum and the abdominal pelvic cavity, or is it outside of that, so to speak? So it's detail that is really minutia, I call it. Some instructors, they will want you to make sure that you understand that, that part of this ureter is outside the cavity, so it's going to be a certain kind of connective tissue, and then the part of it that's in the abdominal pelvic cavity, transporting urine down to the bladder, parts of the ureters, it has another type of connective tissue, and thus a different term. I don't care. It's an outer connective tissue, adventitious serosa. It's no big deal. It's a connective tissue layer, and they all have basically the same functions. All right, so the urinary bladder is much larger, and so you get a pie wedge. It's kind of like looking at the stomach slides. You don't really get the whole thing. But with the ureters, you can see a mucosa that's composed of transitional epithelial tissue. You have a muscularis layer, which is smooth muscle. It has two layers, and it propels fluid just like we do what's called like that peristatic circular longitudinal muscle coordination, to propel and squeeze fluid, in this case down to the bladder. And then you have your outer connective tissue. The urinary bladder the mucosa of the urinary bladder is the same as the ureters. Transitional epithelial tissue. You have a smooth muscle muscularis layer. There are three layers to it, like the stomach, and it's called the detrusor muscle. And then we have the outer connective tissue layer. So, like any muscular layer, it's what is its function? To contract and, to contract, really, that I would accept that. That it's, you're propelling food in the bladder. You want to contract the bladder so the urine has only one way to go, out the urethra, and is expelled from the body. So the function of the ureters is transporting urine from the kidneys to the bladder, and the bladder stores the urine until it's ready to be evacuated. And then the urethra would be a passageway, transports urine from the bladder to outside the body. Okay, we're going to look at some of these features and aspects of urine testing. I want you to know what specific gravity is. Specific gravity is the concentration of urine compared to water. Water is considered 1.00000. So that's your starting point. And urine should always have a certain amount of particulate that you're eliminating, you're cleaning, from and filtering from the blood that needs to go out in water. So the specific gravity should always be normally higher than 1.000. So we have the specific gravity term, or the specific gravity of urine, and then the color of urine. We have the term, the reading, and what it might look like, its appearance over on the right hand side. So the normal specific gravity range of urine is 1.005 to 1.030. And generally the color will be a pale yellow straw color. If we have concentrated urine, which is normal in the morning, to find with your first morning void that the urine is darker in color because during the night you secrete a lot of antidiuretic hormone to reabsorb water when you're forming urine, because you're not taking in any more fluids, and you need to maintain appropriate blood volume and blood pressure. So the amount of solute you're getting rid of and waste material you filter from the blood is the same. You're either transporting it maybe a quarter cup of urine that you produce, or a cup or 2 cups of urine. So if we have a lot of solute in a small amount of fluid, it's going to be concentrated. And that generally, if you obtain a specific gravity greater than 1.035, then we consider that concentrated. And generally the color of the urine is going to be a darker yellow or amber color. And so just by looking we're using a lot of antidiuretic, aldosterone, the hormones that help reabsorb water. And if it's dilute, it means, we're getting rid of a lot of excess fluid, so to speak. All right, so the first morning void has a higher specific gravity. Why? Well, because, as I just said before, and it talks about it in the notes, is that, when you're sleeping, you're not taking any more fluids, and you're going to reabsorb water, and but the same solute will be amount of solute that's filtered out is going to be passed down into the bladder, and so it's going to be more concentrated and therefore have a higher specific gravity, much heavier and denser material than plain water. What endocrine disorder might chronic low specific gravity values indicate? So what that would be indicative of a hyposecretion of antidiuretic hormone. Talked about that briefly in the endocrine system, and that would be diabetes insipidus. There was something else I was going to mention about the specific gravity, and what I wanted to say was we're not really going to be looking, unfortunately, at the chem strips that you use, but for the chem strips, you can have varying numbers of reagent pads on there that are testing for the presence of different things that could be in urine. And, the level of sophistication or the number of things that you can test for, kind of go on and on and on, because anything that's really could be found potentially in urine, you could have a reagent pad, which has, a substance on it that's there to detect a particular thing, maybe hydrogen ions to determine pH. The concentration of urine, like in specific gravity, proteins, ketones, glucose, bilirubin, different hormones, that generally that's done differently, but theoretically, you can use that urine to identify the presence of all kinds of different recreational drugs. and different hormones and byproducts of metabolism that are spilling over in urine. The range for specific gravity, even though the normal range is 1.005 to 1.030, the reagent has the scale that it will detect can be broader than that, about 1.001, to 1.040 even. So, or 1.045. It just depends on the manufacturer and how sensitive and broad the scale is going to be for that particular analyte. And you can see on the side of the bottle or on the box of these containers of chem strips, you can see how broad and how sensitive the scale is, and it'll give the different units of measurement for each substance it's trying to detect. Okay, renal threshold is about the maximum ability of a proximal convoluted tubule to reabsorb certain things found in filtrate, especially initially. And glucose is one of those things. So what we're going to see is that as long as glucose and amino acids are of normal ranges in blood, at the proximal convoluted tubule, 100% of the glucose and amino acids will be able to be reabsorbed at that proximal convoluted tubule. If it's higher than normal, in case of maybe diabetes mellitus, is that the amount of glucose that cannot be absorbed in time, because that's proximal convoluted tubule is so narrow, but long but narrow. It has its limitations as to how much it can ever absorb. There are only so many like glucose transporters. It's under the speed, the rate of filtration is determining how fast the fluid is passing through there. But even when it's of a normal glomerular filtration rate, you have a limit as to how much it can absorb. And that's what we refer to as the threshold. It's generally 180 to 185 milligrams per deciliter. So when those glucose levels exceed that in blood, then you start to have spillover of glucose into urine, because what we'll see is that it's only at the PCT that we are capable of reabsorbing glucose and amino acids. It doesn't have an opportunity later, as filtrate passes through the rest of the nephron. So you have this one-time opportunity, and therefore, as it spills over, it's a really good place to check to see, as an initial scan of, hey, are we getting some proteins in urine, or are we getting glucose in urine, and why? Sometimes it can be explained. We'll talk about that, briefly. And other times, it really never should be found there. The normal fasting blood glucose levels are 70 to about 100 to 110 milligrams per deciliter. Most nursing books are going to use 70 to 100, but some may actually include like about 110. But I would say safely 70 to 100 to be consistent with most nursing textbooks anyway. Okay, so then we're going to move on to the urinalysis portion. In the lab, you would actually do this, but I just want you to know theoretically, what would you find? You can read through the directions, because we had 4 different specimens. One specimen came with a chem strip already dipped, and with an arrow pointing to the pad, they wanted you to match up to the side of the bottle to then go, okay, we're saying just look at that one, so you match your chem strip up on the side of your bottle or your box, and then you move it back and forth to the right or to the left to see which color matches up and what is the value, of that. It's like testing the pH. So that's one of them. The other one was just clearly red, so that was indicative of blood. The other 2, you were to specifically try to find which reagent pad had the color change, but you were only looking for 4 different things, using either the ketone, glucose, hematuria, or blood, or the protein pads. Okay, so you can read to the how it you do this, but you use the handle of the chem strip. You do a quick dip into your specimen, and I will tell you, you very quickly dip and then put on the horizontal, and let it maybe lie on a paper towel, so that as you dip in and out, the urine and from one reagent pad does not travel down to the other and to the next one, because you're holding it with the handle upright after you dip in, and the fluid's going to flow down to the end of this reagent pad, in which case it has the potential to contaminate other pads, because you don't want the urine, you don't want to hold it test strip upright, because the urine or specimen would drip down onto your fingers. So you dip quickly and then you just put it horizontal, right on a flat surface, so that if it kind of travels anywhere it travels to and wicks to the paper towel underneath it, you'll always get a little bit of, the specimen rolling down the reagent pad, but you just do it as quickly as you can. In a laboratory, they are on the horizontal, so you don't get that contamination. All right, so it says person ABCD, but it's specimen ABCD. You would write in the normal value that you saw, what sign might it be indicative of, and what might be the etiology or cause. All right, so up on top here, we have the signs that you would choose from. It's either going to be, and only used once, ketonuria, glucosuria, hematuria, proteinuria, ketones in urine, glucose, blood in urine, protein in urine. Then we have different causes, and really you're not limited to these either. Diabetes mellitus, that gets used more than once. Starvation, anorexia, injury, disease, increased blood pressure, low carbohydrate diet, which is kind of like the keto, the keto diets. Unusual pregnancy. Not all pregnancies, but meaning unusual pregnancy. I think in the notes, it says, I'm changing that actually to unusual pregnancy. I think it says pregnancy in there. Doesn't mean that if you're pregnant, you will find these things. But sometimes during certain phases of pregnancy, you can start to develop what's called gestational diabetes, where you have, problems managing appropriate glucose levels. You can have protein in urine, different reasons. Okay, so you would write in maybe one or two different etiologies as to why you might find protein in urine or blood in urine. All right, then we move on to exercise 6. Identify the substances that are absorbed and secreted along the tube pathway of a nephron. Also identify the hormones responsible for absorption where applicable. All right, so this is consistent with, this is also in the notes for here. It's also from my lecture notes, is you have to determine, what is filtrate and what do we normally find there, and what should we not normally find there right at the beginning. Right? So normally found in filtrate is water, glucose, amino acids, sodium, potassium, bicarbonate, really different hormones, anything that's being transported in blood, that's of a molecular size that can get through the capillary walls, like any capillary, even in systemic circulation. What should not be found are things that are generally large, your formed elements and albumin, red blood cells, white blood cells, platelets, and albumin. Right? They should not be found. Now, under abnormal circumstances, then we might be able to explain why it's there, and it may be temporary, but we should not normally find them, period. Here we have a chart that includes the nephron parts to the left, starting at the renal corpuscle, proximal convoluted tubule, descending loop family, ascending loop family, and distal and convoluted tubule, distal collecting tubule, and distal convoluted tubule, and the collecting ductal tubule. Hello. Okay. Then we have on the top our parts of formation of urine, or I should say, the different phases of urine formation. And that includes filtration, reabsorption, and secretion. Okay, so filtration occurs once and once only, right at the beginning of this process. And that's there within the renal corpuscle at those glomerular capillaries. So right there, as the molecules under hydrostatic pressure, anything that can fit through the capillary walls will hit the Bowman's capsule and now start to enter in the proximal convoluted tubule. Okay? So what should never be found at that point are your red blood cells, white blood cells, platelets, and albumin. Okay, then we enter into the proximal convoluted tubule, and this is where we can either potentially reabsorb or secrete things. Sometimes we have the potential of both, sometimes we don't. And you need to know what happens in each. And you also need to be able to apply this to pictures of the models. Okay, so reabsorption means, and let me just back up and say that the fluid now passing through that nephron is referred to as filtrate. And it is considered filtrate until it drips out the collecting duct into those minor calyces, and then we refer to it as urine. All right, so while fluid's in a nephron, it's filtrate. Once it's out of the nephron, and working its way to the bladder, then we call it urine. Okay, so reabsorption is material going from the filtrate back into the blood, through, either being transported through the vasa recta or the peritubular capillaries, or perhaps more material in the peritubular capillaries or the vasa recta still need to be secreted into the filtrate, and that would be secretion. So not everything is going to be reabsorbed or filtered out in the glomerular capillaries. Right? So as the blood leaves through the efferent arteriole, and now we're passing through those capillaries, as mentioned before, you have further opportunity to either get rid of some more substance by secreting it into maybe a distal convoluted tubule or a proximal convoluted tubule or into a loop of Henle, and what might be reabsorbed because we don't want to necessarily get rid of it. And each area of the nephron has certain reabsorption or secretion capabilities or lack thereof, because each one is lined by really different types of epithelial tissue. Remember, the capillaries are one single layer of simple squamous epithelium, and the histology of a nephron is also a single layer of cuboidal cells, columnar cells, squamous cells, but they will be adjacent to those capillaries. Right? So just like a respiratory membrane where you have two thin layers of tubes coming adjacent to one another, where diffusion can occur, or you can pump stuff across, that's how this is going to work. It's because they're so proximal to one another, a single layer of cells, right, that you can get movement of material from one to the other. All right, so proximal convoluted tubule, what can be reabsorbed really about anything that's found there? Water, sodium, potassium, about 65% of that. Glucose and amino acids, as long as they're of normal values, in blood, then 100% of it will be reabsorbed. And when it comes to bicarbonate, about 85%, depending. It just depends on the level. Just a second, I need to turn off my phone, because sometimes all of a sudden I'll get a text and they'll start to give me that kind of the ringtone thing for it. I don't want to disturb you. Okay, so a lot of absorption occurs in the proximal convoluted tubule. It's kind of like a small intestine, very narrow, kinked on itself. Right, so that's its job. Reabsorb a lot of material that, even though it got through the filter, because the filtration at the glomerulus is not filtering based on necessity and what I don't necessarily want to get rid of, because you never get rid of glucose and amino acids, because glucose is the preferred molecule of cellular metabolism, right? And amino acids are the building blocks of all our complicated proteins. So we don't want to get rid of them unless they're too high, too high. So the first thing we do is we take back everything we just don't want to get rid of. Just because they were of the size to get through the filter, doesn't mean we want to pee it away and eliminate it. All right, so those things can be reabsorbed, and what can be secreted are generally hydrogen ions, ammonium ions. Ammonia, we've never reabsorbed that, and some drugs and hormones like human chorionic and gonadotropin. All right, then we enter into the loop of Henle. We have the descending loop of Henle. It is permeable to water only, to reabsorb water. Then when you go through the hairpin turn, that's Wormers because it's composed of simple squamous epithelium. Then we enter into the loop of Henle. We change epithelium to simply cuboidal. Now we are reabsorbing just ions, sodium and chloride, and maybe potassium. Then we enter into the distal convoluted tubule and the collecting duct. And together, here, we just kind of lump those together. We're modifying, and as the filtrate is going through the ends, the last parts of this nephron, think of it this way. This is your last ditch effort to modify two major things: blood volume and blood pressure, and buffer the blood. So now we're going to look at the renal compensation, how we might adjust the pH of blood. So if we want to reabsorb sodium and chloride and secrete potassium, and reabsorb water, that will be the action of aldosterone. So maybe I suggest like over to the left here, or to the right, wherever you may be right in there with a little bubble or something, aldosterone. Then we have just water alone, perhaps. That would be antidiuretic. Calcium, parathyroid hormone, or PTH. We don't want to forget that because we can reabsorb calcium there. And then we can reabsorb or secrete bicarbonate. So here under reabsorption, we have bicarbonate and hydrogen is needed to buffer. And over here on the secretion side, bicarbonate and hydrogen ions, more or less as needed to buffer the blood. So what do we mean? Well, the aldosterone and antidiuretic up here, we know how that works now, ad nauseum, because we're going to increase blood volume and blood pressure, or we don't secrete those at all, and we let fluid pass through the kidneys and just produce, decrease your blood volume and blood pressure. We don't generally, unless it's really high, require atrial natriuretic peptide. Okay, but when it comes to pH, you have to know what adjustments you're going to make, right? So when we have the normal pH range of 7.35 to 7.45, then if you have a pH value less than, and this takes us into this next exercise here, the exercise 7, we're going to talk about what modifications or what will be secreted and reabsorbed in the event that we have lower than normal blood pH or higher than normal blood pH. Kidneys play a major role in regulating blood pH. The PCT and DCT exchange hydrogen bicarbonate as needed. So select, circle, or underline what happens to the hydrogen ions and bicarbonate ions, whether they're reabsorbed or secreted under the following conditions. So A, if the blood pH is low, lower than normal, am I acidic or alkaline? So you'd be acidic, right? So if you're acidic, let's say you have a blood pH, it'll make this easy, 7.20, and we need to raise the pH up to 7.35. What am I going to do? Am I going to secrete or reabsorb hydrogen ions? And am I going to secrete or reabsorb bicarbonate ions? Right, so look, if the hydrogen ion concentration is too high, that's what's dropping the pH, then I'm going to secrete hydrogen ions and I will reabsorb bicarbonate. We'll move in opposite directions. And if pH is too high, which is called being alkaline, then I'm going to, if I can, reabsorb hydrogen ions and secrete bicarbonate ions, just the opposite. All right. So this is what's going to happen at the where we have our peritubular and vasa rectus, is that we are going to be modifying the pH of the blood that's passing through those particular vessels. This is what we call our renal compensation. The kidneys, and as long as you have normally functioning kidneys and a respiratory system, we said this before, that for whatever, the kidneys will try to, will adjust the pH of the blood currently passing through there, and the respiratory system adjusts the respiratory rate depending on the pH of blood that's passing through the different chemoreceptors, internally found, in the body. And your respiratory system adjusts to that. Do I need to increase my respiratory rate and blow off carbon dioxide? Or do I need to slow down my respiratory rate and maybe let carbon dioxide kind of build up and increase the hydrogen ions and decrease the pH? So this is all carbonic acid cycle things. So when it comes to carbonic acid cycle, now we're looking at the far right-hand side. When carbonic acid breaks apart and dissociates into hydrogen ions plus bicarbonate ions, now we're looking at, hey, it's the kidneys that can adjust also those hydrogen ions and bicarbonate ions by reabsorbing and secreting as necessary here. Okay, so I'm going to break that share. We've gone through that. Now I'm going to switch my page here and get into the some of the images very quickly. This is kind of a long lab, and I don't want you to get too well. I don't want to go so quick we don't see them, but I also don't want to take too long and get into too much detail, because the urinary system is a very important system, just like cardiac. It's just kind of underrated. Okay, so we're going to look at anatomy. So here we have sideways, of course, but we have kidneys, ureters, and the bladder. You should be able to distinguish between a right and left kidney. How do you do that? The easiest way is that the inferior vena cava is always on the left-hand side and your aorta is on the right-hand side. All right, so here we have a kidney, the ureter, functions to transport urine to the bladder. Urinary bladder stores urine, contracts during what's called micturition, controlled by the autonomic nervous system. It may be good to know that stimulation of that organ is through the is controlled by the parasympathetic system. That's actually rather helpful. Right? Remember, the systems that are increased in parasympathetic stimulation are your SLUDs, salivation, lacrimation, urination, digestion, defecation. Okay, this is the bladder. It's pointing to its three layers: mucosa muscularis, an outer connective tissue layer, and the tissues that might be found there. Mucosa is composed of transitional epithelium. The muscularis layer is composed of smooth muscle called the detrusor muscle. Has three layers, and it functions in micturition, which is the muscular layer anyway. Is the contractile layer, so it functions in micturition to expel the urine. And this starts talking about the layers, so to speak, of a ureter. Pretty much, this is really a ureter. Ureter is really the structure that has half serosa, maybe not even really half. It's even less than that, but it's kind of half and half because parts of it are found outside the peritoneum and part within it. Don't worry about that. Just know it's an outer connective tissue layer. That's it. Because it really is referring to the ureters and not the bladder. All right, the bladder is within. All right, now we have a picture of a gross model of the kidney. We have the outer layer called the cortex. We have two pointing to a pyramid, and those dark staining pyramids that are triangular shaped. The region is called the medulla. And then we have the tube systems that are transporting urine now. Three, these are the calyces to the renal pelvis. So we have the region of the cortex to medulla, renal calyces. You have minors and majors. It's kind of like small veins merged to form larger veins. Then we have the renal pelvis. And then further would be the ureters after that. Right here, we're looking at a renal corpuscle. It actually lets you see well, let's just keep it simple. The afferent arteriole is number one, the glomerular capillary is number two, and the efferent arteriole number three. Where the afferent arteriole meets that yellow tube system, that's a distal convoluted tubule to the right-hand side at 3 o'clock. Where those two layers of cells meet, the red tube, like the yellowy part there, that is the area where you have the juxtaglomerular cells and the macula densa cells. That's your juxtaglomerular apparatus. But it also here, superficial to the And surrounding the glomerular capillaries too, you can see that Bowman's capsule. And then to 9 o'clock there, that would be the beginning of the proximal convoluted tubule. Right, so these first images are showing you the blood pathway into and around the nephron, with afferent, efferent arterioles, glomerular capillaries in between. It's at the glomerular capillaries that you have filtration, and the efferent and afferent arterioles, remember, are capable of vasoconstriction and dilation, so they're under the control of the autonomic nervous system primarily. All right, these are different models that can be used. This is a good one for showing you peritubular capillaries at number 1. And if we scroll down a little farther, just to the base of this image, it shows you a capillary bed surrounding these loops of Henle. And those are the vasorecta. And so here you have peritubulars, vasorecta. It probably would have been, this is just identify. We are going to go back and look at exactly the parts of the nephron. Maybe they could have been, I think it's helpful to look at the parts of the nephron first so that you understand the vasorecta surrounding the loops of Henle, and you've identified what loops of Henle are, but in either case, it's one half dozen or another. You have to start someplace. All right, so we're saying, what is the process? If material goes from A, which is part of a nephron, into B, a blood vessel, that is called reabsorption. If additional material goes from a capillary, into a tubule system and into filtrate, that's called secretion. Okay. This will make more sense when we kind of come full circle, hopefully. Okay, now we're going to use that model as well as another one. This is a very colorful one, but it's easy to kind of follow. So now we're going to look at the parts of the nephron, starting with the renal corpuscle here. We have the outer surface, which would be the Bowman's capsule, and inside would be the glomerular capillaries. Right, so that is number 1. And then leading from there is the orange tube system. That would be the proximal convoluted tubule. And what you would do in face-to-face is you start with the renal corpuscle and kind of follow the tube system to identify, hey, is that the PCT, and then keep following it. And then you can kind of color identify which would be. If you follow the colored tube system, you would then be able to identify what would be the descending loop of Henle, which one would be the ascending loop of Henle, which then continues as the distal convoluted tubule, and then what would be the collecting ducts. Over to the left-hand side, I would say that, these are good examples of how you can tell, what is an afferent and efferent arteriole, even on this model. The afferent arterioles are larger diameter than the efferent arterioles, because if we're losing a good amount of filtrate, or we're producing filtrate from the blood at the capillary level, so clearly we're losing some of the contents of blood volume and parts of it. And I don't mean like really parts, I guess I should say molecules that were components of it. And the vessel that leaves doesn't need to be nearly as large a diameter as what entered, because we've lost a lot of that volume. And that is the fluid and the filtrate that's passing through the nephron. There's something else they're trying to tell you here, is that this on the horizontal here, the large blue and red vessels here, that is the border between superior to that would be the cortex, and inferior to that would be the medulla. And you can tell the direction of blood flow also because you go from large red diameter vessel to smaller ones in the cortex here. Then you have now followed the direction blood would be flowing, which is through the afferent arteriole into the renal corpuscle and out as an efferent arteriole. Right? Then it gives off those branches, like we just showed before, the peritubular capillaries in the cortex and the vasorecta in the medulla. So I try to point out things while we're here, because that's a good picture. It doesn't necessarily have arrows on it, but let's take a look-see anyway. And that's 1 and 2. Then we have the descending loop of Henle. Remember that proximal convoluted tubule is orange, so just follow that, and that becomes the descending loop of Henle in lavender. You do a hairpin turn at the bottom, and now you ascend as the ascending loop of Henle for. You should know what is being secreted or reabsorbed at all these stages, because I could point to, and let me just give you the next. Let's say here we were just identify 3, identify 4. That could be a quiz question. Maybe what is reabsorbed at 3? What is reabsorbed at 4? The same at the proximal convoluted tubule. I could point to a renal corpuscle and say, what process of urine formation occurs here? Well, that would be filtration. I could point to a proximal convoluted tubule and ask you, well, what's reabsorbed here? What might be 100% reabsorbed from that proximal convoluted tubule? I could point to it and say, what region of the kidney must I be in? Cortex versus medulla. Okay, so the more you keep looking at these, and then you use the exercises performed in lab to apply to these models. Okay, then we have lastly, because the ascending loop of Henle was in lavender here as well, we have the distal convoluted tubule and then the collecting ducts or the collecting tubules. What's secreted, what's reabsorbed? Okay, this is a good one too. All right, so we know that at the end, what if, that we're trying to adjust primarily? We either have hormones targeting it to increase blood volume and therefore blood pressure, right? Somehow reabsorbing water, right? Maybe parathyroid hormone stimulating secretion of calcium. Reabsorption, I beg your pardon, of calcium. And then we might be adjusting blood pH by secreting or reabsorbing hydrogen or bicarbonate ions as needed to buffer that blood, to either modify the blood pH back into a normal range of 7.35 to 7.45. All right, so maybe I could ask you, hey, identify one hormone that would target 5 or 6 even, that stimulates the reabsorption of sodium and chloride and secretion of potassium. That would be aldosterone. Identify the hormone that targets 5 or 6 or just 6, to reabsorb calcium. That would be parathyroid hormone. What might I secrete into, what would I secrete into 5 or 6 if I had a blood pH of 7.5 or 7.25? All right, so now start looking at this and going, okay, given that chart of what's secreted and reabsorbed, what would be going on here? What would be being secreted or reabsorbed? That's applying the physiology, to these models. Now here is another great model, right? This is pointing to this, the nephron. One is pointing to, that whole white ball, and the capsule white part to the outside, and the capillaries, glomerular capillaries to the inside. It's a renal corpuscle. This is great because it really shows you where all those renal corpuscles are located in the cortex. Remember that horizontal artery and vein is indicating the border between cortex superior to it and medulla, a renal pyramid below it. Right, so the regions are cortex and medulla, and that red area were 4 and 3, the whole big red area. That's called our renal pyramid. They are found in the medulla. All right, so to the top, we see where all those renal corpuscles are. That's going to help you histologically to identify where you are. And then we have, look at the other parts of the nephron that are found there in the cortex. So by looking at its entirety, starting at the renal corpuscle, 1 to the proximal convoluted tubule, descending loop of Henle, ascending loop of Henle, distal convoluted tubule, and collecting ducts at 5 and 6. So look at the parts that are found in the cortex versus look at the parts that are found in the medulla. Right? And keeping that in mind, then it's easy to identify what region when you're looking at a slide that you're looking at and what you potentially are looking at. Here's another type of a model that's showing you the same thing. 1, 2, 3, 4, 5, and 6. Let me back up real quick. This actually, let me go back. Even though it's not pointing to it, you look at the blood supply and trace the blood supply into and out of the nephron, because this lets you see, in its entirety as well. So starting kind of at that horizontal point, the big red vessels, you follow it up and you see by number 1, the afferent arteriole entering into the renal corpuscle, the glomerular capillaries inside at number 1, and then right under the arrow 1, you would see there that would be an efferent arteriole leaving there, and it branches off into that network, that capillary network surrounding 2 and 5 here, in the cortex area. Those are the peritubular capillaries. Farther down, surrounding 3 and 4 here, you see that funky network down there? Those are the vasa recta. And then they all gas exchange and merge into one big blue vessel, and then they become large, smaller veins to larger veins, ultimately to a renal vein and to the inferior vena cava, and now back up to the right atrium. So I like this one also for looking at all the blood supply into and out of the nephron, in addition to the parts of the nephron, if that makes sense. All right, this is a slide from the renal, the cortex region. These here at the tip of the pointer, that whole structure is a renal corpuscle. You can see the Bowman's capsule to the outside. So you see these repeat, these knobby, ball-like structures. You must be in the cortex. Other things that might be found there on end, you can see them. Those are proximal and distal convoluted tubules. An afferent or efferent arteriole here and there. Those are a little harder to identify. But maybe even a collecting duct, because those are the structures found in the cortex. This is magnified. Right, so identify the structure, give a function, and maybe what region, cortex versus medulla. Right. So it's a glomerulus, filtration, from the cortex. That's what the pointer is pointing to. This is from the bladder. We're looking at the mucosa, and then you have a muscular layer, an outer connective tissue layer, urinary bladder. You're looking at the mucosa, transitional epithelium, and then below that would be the muscularis layer. Being in the bladder, then that would be the detrusor muscle, smooth muscle. Its function, just the muscle itself, is to contract, or act and participate in micturition. The whole bladder as a whole functions to store urine. Right? All right, so you should know hormones, action of antidiuretic on A, aldosterone on A, because this had a little A, but it would be a distal convoluted tubule also. Maybe even parathyroid hormone, right? Because that was in the chart. So this is identifying that. Right? I'm going to kind of zippy through this a bit. There should only be maybe a few more. This is just showing you what if we had tested and you had results of specimens, is that what might be, as I said, like we talked about specimen A, B, C, D. One was red. One is supposed to indicate hematuria, glucosuria, proteinuria, and so forth. To the side of the bottle here, to the left-hand side, it tells you what you're looking for: pH, specific gravity, ketones, and you match the handle on the bottom part here. You can barely see it in like a pale gray, and you would match it up and then read across each colored reagent pad to match up your color change on a pad, and then look at the value on the bottom of that. Let's say for specific gravity, it might be 1.0 1.0, to 1.045, and you just take that home. Same with pH. That's what this is about. I don't recall, I don't think there are any that specifically show you. Face to face, we put out reagent heads for you. Okay, so that is the last image from that urinalysis lab. I want to go back and quickly just go through the notes, the PowerPoint notes, because there are some really good images in there. And again, sometimes I use those images. So let me quickly change my share. So we go into the notes, and then we will be done. Okay, so here I'm in the course page. I've got the PowerPoint up. This talks about the gross anatomy. You can read through that on your own. This is what supports, the functions that you're responsible for. Pelvis. Some of these pictures are excellent from a former image database, identifying all the parts of the kidneys. I think they're excellent. About the urinary bladder, this is all the gross anatomy, and then the microscopic anatomy of the different layers. The urethra, there's our bladder. This is our circulatory pathway, starting with the renal artery, and then to the afferent arterial, glomerular capillaries, efferent arterial, so forth and so on. This is what I meant. I knew I had another picture of that one model. And so you can see the nephron in all the, I don't know, whitish tube system here. But then you can also label up the circulatory pathway through it. So I think this picture is excellent for that. The capillaries up here to above B, which for some reason aren't identified, would be the peritubular capillaries. But you have afferent arterial, efferent arterial, the vasa recta, the glomerular capillaries, and above where D is, those surrounding the proximal and distal convoluted tubules there, those would be the peritubulars. Here, C is pointing to it. Thank goodness. So that's excellent image, and you can really distinguish between them all. I love that. The microanatomy, the nephron is the repeating structural and functional unit of the kidney. Very important to know. All right. Talks about the nephron eliminating waste and so forth. We control blood pressure here. We contribute to blood volume, blood pressure. The renal corpuscle, its composition. We have hydrostatic pressure that filters just like any place else at a capillary bed, right? The tube system, thereafter filtering in urine producing at the glomerular capillaries, or PCT loops of the distal convoluted tubule. We have the juxtaglomerular apparatus. That is where the distal convoluted tubule, some books consider the distal end of the ascending loop of Henle, but most of the time it's going to be referred to as a DCT, and the afferent arterial are adjacent to one another, and they communicate back and forth. Right? They affect each other. The juxtaglomerular cells in the afferent arterial secrete the renin, and the macula densa cells in the distal convoluted tubule are detecting changing levels of sodium and chloride. Thus, those levels are indicative and a direct indication of your current glomerular filtration rate. We talked about that in lecture. It should be about 125 milliliters per minute. Right? If it's higher than that and lower than that, what would happen to the sodium chloride content, of your filtrate? And so you should at least know this anatomy and what cells are found there, and at least where renin comes from. This lets you see that as well in this diagram. Right? It's excellent. Right? We have the distal convoluted tubule, the macula densa cells there indicated in purple, and then you have the afferent arterial, and the juxtaglomerular cells are those cells closest to the macula densa cells, and together they have the juxtaglomerular apparatus. Renin is secreted into the bloodstream by those juxtaglomerular cells of the afferent arteriole. Afferent arteriole is capable of significant vasoconstriction dilation, therefore it regulates glomerular filtration, and it has a big impact on that. All right, here we have a lovely picture of a renal corpuscle found in the cortex. Here you can see the Bowman space, the capsular space, the Bowman's capsule to the outside, the glomerular capillaries to the inside. This where you have the DCT on the bottom and this afferent arteriole at about 2 o'clock from there, 1 to 2 o'clock, I would say. You know, that is a juxtaglomerular apparatus there. I think that's beautiful. Remember, the glomerular filtration rate is about 125 milliliters per minute. This explains it, right? That the higher the filtration rate is, the faster the fluid is passing through this nephron, the faster the conveyor belt. Thus, we have less opportunity to reabsorb sodium and chloride and fluid, so it's in the tube system and going out as urine. So we have increased fluid loss and increased ions infiltrate. If the glomerular filtration rate is low, we have plenty of opportunity to reabsorb water and sodium chloride and things. So the concentration, you have decreased urine output, you have less sodium and chloride in there, and so that gives you an indication of the glomerular filtration rate. Let's see, we can go ahead and read through that. This starts to enter into the chart that I had included in the lessons that we just covered. Apply those to the parts of the models, and parts of the nephron, or maybe even the cardiovascular or the blood pathway through the kidneys. This talks about the hormones, aldosterone, antidiuretic. Where do they come from? They're negative feedback loops. Parathyroid hormone, don't forget, even though that's not in here, it's part of it. Right? This was just used to be a particular little exercise we did, but we now incorporate that into everything else, into another chart. All right, urinalysis, what these things mean. All right, as stated before, if ketones are present, ketonuria, some possible etiologies. We can, these are some that you can include as well. Anorexia, pregnancy or maybe unusual pregnancy. DM is diabetes mellitus. Glomerulonephritis is an infection that has traveled not just, it's not just a urinary tract infection like the lower portion of the urinary system, like the bladder and the urethra. This has now traveled all the way up the ureters and is affecting the kidneys themselves. And that's considered glomerulonephritis. Okay, so other excellent pictures and very useful for testing, quizzes and exams. The renal arteries, renal veins. Here we have identifying even the rights and lefts of renal arteries, renal veins, the abdominal aorta, inferior vena cava. Images that you're familiar with, you should know right versus left. This is the same structures from that you looked at on other models. These are just different other models we have in the lab. And so you're always responsible for everything in there. This is on the vertical plane. You can see now these nephrons and what their parts are. Kind of quickly, here we have, again, similar to the other models we looked at. They're just kind of different color coded. These are a little bit older than the other ones, and the images that we formerly looked at, identifying the same anatomy. What's he doing? Again, here we have a newer model, but identifying the afferent arterioles, glomerular capillaries, Bowman's capsule, proximal convoluted tubular F. Where B and A meet here is the juxtaglomerular apparatus. This is excellent. So I'm not going to belabor this. You can use these, and please do, as a studying tool. They all have legends that label them up as to what you're looking at. Right. This takes that whole big model, and instead of having arrows on them, it kind of gives you a verbal description, like the orange tubing is the proximal convoluted tubule and the descending loop of Henle. So I think that's helpful. This is the histology. Excellent pictures. They're well labeled. This is clearly from the medullary region because I don't see any renal corpuscles. So these must be, proximal, loops of Henle, either a descending, ascending loop of Henle or a collecting duct. Here we can see renal corpuscles, so at least I know I'm in the cortex. That same nice picture that we looked at before. And that's it. All right, so that is the end of the urinary system. Sorry, I can't walk and chew gum at the same time sometimes. Of the urinary system, I just want to keep in mind. Okay, so we covered everything. There is a lot to this lab, undoubtedly. But the next one, once we start getting into reproduction, the first part of that is just male and female structure function. That's going to move very quickly. But I understand, like, there is a lot of physiology to this, but you are going to use this kidney function every day of your life, really, as a nurse. Reproduction. All right, you do have to know, the parts of reproductive anatomy and functions in any male and female that you look at, but almost, generally, unless you're working in particular areas of the hospitals like that, going into extraordinary detail where it isn't exactly something you're going to be applying probably to most patients. They're not, depending on what department you're in, they're not necessarily there for reproductive issues. But you do have to know, of course, the anatomy and things, absolutely. Yeah. But I will tell you that urinalysis and how kidneys work, and especially here in Florida, where you have a high geriatric population of people, is that understanding blood pressure and urinalysis, and you are going to be doing this so frequently, is getting blood specimens, getting urine specimens on a regular basis from patients and sending it down to the lab to currently assess what's going on with these patients. So urinalysis and blood analysis are every single day, and so when you understand, why certain drugs are going to be applied, potassium sparing, Lasix and things like that, is that you're affecting water reabsorption, the effects of antidiuretic and aldosterone and maybe renin, and you have to keep coming back to the kidneys, and you do that way more frequently than reproduction, unless you work in like the women's health area, you work in, in OBGYN somehow. All right, that's a specific specialty. So it is just very important to understand this. You will use it over and over again, I'm telling you. All right, well, that is the end. I'm going to stop my share, and yeah, that's it. We are done.